The following podcast is part of a certified educational activity titled Precision Medicine Crafts a New Story for Metastatic Prostate Cancer, the next act of therapeutic intensification with AKT inhibition and beyond. Access the entire activity and complete the post-test at peerview.com/ZXT860. Downloadable slides and practice aids are also available.
Hello, everyone. So, our goal tonight is really to speak about precision medicine for patients with metastatic castration-sensitive prostate cancer, which is something we haven't done until now, unfortunately, as compared to many other cancers. When you think about lung cancer, breast cancer, colorectal cancer, prostate cancer really stands as an exception. At least for hormone-sensitive disease. Of course, we are doing precision medicine already for castration-resistant disease, and we really hope we're going to change things for metastatic castration-sensitive disease. All right. So I'm Corinne Fizazi, medical oncologist from Gustave Roussy in France, and I'm delighted to be together tonight with Dr. Tanya Dorf from City of Hope, and also Dr. Dan George from Duke. All right, so our goals, our scientific goals for tonight, basically three things. We want to speak about pathways, and we'll really try our best to simplify the biology. So we'll try to simplify what we know regarding the pathways cancers like to use to progress. Second, we will look at the existing clinical data for efficacy that actually targets those various pathways for castration-sensitive disease, sometimes castration-resistant disease as well, and also look at what's next, or what are the ongoing or planned trials. And third, we will also discuss the limitation and, of course, the adverse events that patients may suffer from when targeting those pathways to try to figure out better what is the ideal balance between benefit and risk. So this is, in short, the natural history of a disease. You may have seen that 100 times, at least I have. And this is trying to represent the burden of the disease, how it reacts when we are treating these patients with hormonal agents, chemotherapy, bone-targeting agents, and more recently, immunotherapy, PSMA, lutetium, etc., etc. But really the question is, where do we currently stand for patients with metastatic hormone-sensitive disease? Some of this evidence was obtained in earlier stages, and most, of course, was obtained in late stages. So we need to better figure out what's next for patients with metastatic hormone-sensitive disease. And speaking about patients with metastatic prostate cancer, I'd like to remind you that the incidence of de novo metastatic prostate cancer is actually highly variable on the planet. Here in this country, in the US, it is said that less than 5%, and tell me if I'm wrong, of patients who are diagnosed with prostate cancer actually have evidence of metastasis up front, so de novo metastatic disease. It's a minority. In Europe, depending on the country, depending on testing, on various things, the incidence ranges from approximately 5% also, similar to the US, and up to 30%. Now, if you go to other countries, and I chose on purpose China and India, just because the populations are so big, approximately 60 to 70% of patients who are diagnosed with prostate cancer have metastasis from the beginning. So worldwide, this is telling you that de novo metastatic disease is the key problem for this disease. And in other words, localized prostate cancer is mostly a disease of riches. So that, I think, is very important when we think about what we should invent in terms of new treatments if we want to clearly improve patients' outcomes and especially death. And speaking about it, who dies of prostate cancer? This data comes from my country, France, probably similar to the US for many things. And for example, in my country, most patients are being diagnosed indeed with localized prostate cancer when they are diagnosed with prostate cancer, probably 90% or 95%, let's say. But still, the minority of patients who are diagnosed with metastasis de novo represent more than half of the death from the disease, 56% in the study, as opposed to 44% of patients dying with upfront localized disease. So even in all rich countries, where most patients are diagnosed mostly with localized disease, de novo metastatic disease remains the big issues in terms of death numbers. So you might look at this data probably two ways in terms of health progresses. Either, first strategy, consider improving the treatments for de novo metastatic disease. Second strategy, try to diagnose earlier patients who are currently diagnosed with metastasis. And of course, you may debate what is best, and probably both make sense. Also very important is looking at the heterogeneity, the biological heterogeneity in these different situations. Localized disease, metastatic castration-sensitive disease, and mCRPC. This is a complex slide. I'm sorry for that, but biology is sometimes complex. But just have a look, for example, to the androgen receptor, which is, at the end of the day, the main driver of a disease. If you look at the alterations of the AR in patients with localized disease, you will see that only approximately 2% of patients appears to have mutations, for example. So it's really a small minority. If you look at patients with metastatic castration-sensitive disease, not that different, 4% plus or minus, mostly amplifications. Now, if you go to mCRPC, especially after use of AR pathway inhibitors, you will see that many more patients have already developed alterations of the androgen receptor, mostly amplifications, but also mutations in approximately 20% or so. So you can see how the disease is heterogeneous and how it evolves with time, depending, of course, on therapeutic pressure. I'm just taking one example, but of course we will develop more on that. And it's now my pleasure to introduce Dr. Daniel George, who will speak about the current script for metastatic castration-sensitive disease therapies. Dan, please.
Great. Thank you so much, Karim. I'm looking forward to our discussion to follow. I'm going to run through an overview of metastatic hormone-sensitive prostate cancer therapies and maybe some of the data that's shaping how we practice around this disease state. So first off, let's start out from a patient perspective. As clinicians, when we see a patient who presents with metastatic hormone-sensitive prostate cancer, these are some of the things that we're considering as we're listening to the patient's history, as we're asking them questions, as we're talking about them, about the disease state, their prognosis, and how we're going to manage them. Are they fit for chemotherapy? It's a really important question, something we're going to be thinking about up front with that patient. Whether the patient is open to chemotherapy or not, most patients aren't asking for it. It's really important for us to be assessing that. Really, do we think it's the right choice for them? Their fitness for an AR inhibitor and frailties and comorbidities, recognizing that much of the toxicity of AR inhibition overlaps with androgen deprivation therapy, and that for the most part, for patients who can tolerate androgen deprivation therapy, we're also thinking about AR pathway inhibitors. But they're different. They're not all the same. And a drug like abiraterone that requires prednisone that affects other hormonal pathways, has other complications associated with it, including issues around their ability to tolerate, elevations in blood glucose and their risk or presence of diabetes, their cardiac history and other arrhythmia histories, and certainly any liver disease or issues. Any prior therapies that these patients may have had, and in other settings. And then, of course, any non-AR phenotype, as Dr. Fizazi had really nicely outlaid for us there. There's a lot of biology that's present beyond just the androgen receptor in this metastatic hormone-sensitive prostate cancer setting. Sure, that receptor is going to get overexpressed and mutated and activated in other ways in castrate-resistant disease, but so too these non-AR canonical pathways and alterations are going to increase over time as that disease adapts to our hormonal therapy. So recognizing up front what that is, how important it is for patients with metastatic hormone sensitive prostate cancer to undergo some profiling, and not just germline, but also somatic. We mentioned earlier, I think the STAMPEDE trial and the importance of follow-up in these patients. The field of prostate cancer has changed dramatically in the last 10 years. And studies like STAMPEDE have led the way in helping us understand this disease. And historically, if we look at the ADT alone experience, the control arm, if you will, for STAMPEDE, it really did kind of lay for us sort of a natural history of how we've been treating this disease for the last 60 or 70 years. And you can see here in green the progression-free survival rates with an average time, a median time of disease progression to castrate resistance of about 12 months. You can see death here from that STAMPEDE study between 3 and 4 years on average. And you can see on our curve here the sites of metastatic disease having prognostic significance. Soft tissue, largely lymph node disease, has a much better prognosis than patients with bone-only disease, and the combination of soft tissue and bone, particularly visceral disease, really is associated with even a worse prognosis. Add to that now our relatively rudimentary assessments of tumor burden, how we assess volume at presentation. And recognize some of this has been a little bit arbitrary. Some studies have described 4 or more bone metastases. Some have said 3 or more bone metastases with high-grade disease. Some, almost all recognize visceral disease as a high-volume state. So when we talk about volume, we don't mean in a very kind of quantitative way. It's a little bit more in a semi-quantitative way that we're assessing this. And when we draw a line at 4 or 3, the reality is most of those patients are well above that line. If you look at the average volume of disease or number of metastasis in our high volume patients, it's probably closer to 10 or 20. So the truth is that this is a little bit of a low threshold. But when we think about high volume disease, many of these patients are truly multiple sites of disease, and that matters, because if you look here, and Dr. Fizazi mentioned this about sort of those that are de novo having a much worse prognosis in terms of survival versus those that are metachronous. And metachronous, we mean patients who started out localized and then developed metastatic disease at a later date. So if you look here, the de novo on the bottom of this sort of table shown here, the de novo high volume patients, that's the patients with a median overall survival of 3.6 months. That's that red curve on the bottom there. That's the really worst prognosis patients. When you see that combination, beware. These are patients we cannot delay a lot of therapies in. We're not going to get lots of breaks and treatment-free intervals. These are patients that will likely go on therapy and stay on therapy. On the other end of that spectrum is the top of this curve, the metachronous low volume patients. And here we're looking at, more than double the overall survival on average. And this is at the time of metastasis, not from diagnosis, but from metastasis, median overall survival 7.7 years. And if you look at this data and where it's from, this is papers from 2018 and 2019. So it tells you something, right? The studies that we're going to talk about really started being reported in 2015, the earliest ones with chemotherapy and beyond. So this is largely made up of data well before that, from our ADT alone era of managing these patients. And still, we can see a wide spectrum of outcomes associated with this. Now, as we're going to talk about, the field has changed. Combination therapy has really taken over the standard of care in all of our guidelines, bar none. Our level 1 evidence suggests that patients with metastatic hormone-sensitive prostate cancer should be treated with a combination of ADT plus chemotherapy, androgen receptor pathway inhibitors, or a combination of both. And if you look here from 2018, those recommendations have been in place. And what's a little bit disheartening is how long it takes to change our practice as oncologists. But don't fret, it is changing. And if you look in 2017, 2018, 75% of patients were still treated with ADT. But if you look in just the last 2 years, 2022, 2023, that we have data on, the curves are really coming down. Now, some of that may be the fact that we have more options. It's more than just docetaxel and abiraterone, which is now generic drugs. Now we have on-label drugs that I think have real educational programs, like this one tonight, that I think can really help to spread the word on how important it is that these kinds of combinations be adopted into practice. And it makes a difference. Education helps. We're all better for it. So I think that's what you see here. And then on the top of these curves, that yellow block, which again, in just these 2022, 2023, has started to expand, is the triplet therapy with an AR pathway inhibitor and docetaxel. I think really suggesting that too, we're recognizing there probably is a population of patients, maybe larger than we're doing right now, that can tolerate and benefit from those approaches. So our practices are evolving. Unfortunately, they're not evolving equally. So we in the US looked at 2 databases: Medicare database, which is patients over 65 for the most part, and the Veterans Health Administration, which are patients, veterans that are treated through a single payer system. And we looked specifically in 3 groups. We looked at white patients that were on Medicare. We looked at Black patients, on Medicare or on Medicaid. And then we looked at white patients that were on Medicaid. So we looked in these groups. And then we looked in the VA, where Medicare, Medicaid doesn't matter, they're in a single payer system. And soberingly, we saw that our Black patients in the US on Medicare, compared to white patients on Medicare, were treated with combination therapies 32% less likely to be treated with those. We're not adapting the same guideline recommendations in this population, despite the same access to insurance with Medicare. When we looked at Medicaid, it was even worse. When we looked at Medicaid, these patients were treated with 33% less likely to be treated than patients who weren't on Medicaid, regardless, Black or white. And then when we looked at Black patients in the VA system, again, single payer system, 25% less likely to receive combination therapies versus white patients. What does that translate into? In our Medicare patients, our Black patients had about a 20% greater risk of death from prostate cancer. Our Medicaid patients, a 50% greater risk of death from prostate, dying, almost twice as fast or 50% faster than our patients with Medicare. And this is Medicare. We're not talking about private commercial insurance here. Interestingly, in our VA patients, despite that difference in upfront use of combination therapy, they really had about the same in overall survival, Black and white patients. So these are disparities. This is ongoing today, and it's something I think we need to be aware of. Whether it's subconscious, whether it's socioeconomic or other issues, we need to make every effort we can to offer these patients and help these patients, receive and stay on combination therapy. And the evidence is overwhelming. We have a number of level 1 evidence that we see improved overall survival with metastatic hormone-sensitive prostate cancer with treatment intensification or combinations. And I'm not going to go through all these studies, but suffice it to say this has been reproducibly shown over and over again. And maybe some of the early studies were a little bit underpowered and whatnot for an overall survival benefit. And some of this was looking at radiation in ADT. But once we got into the systemic therapies with docetaxel and our AR pathway inhibitors, the results were consistent and really across disease risk groups. And I think that's really important. On the bottom in gray, you see our two big phase 3 studies that have demonstrated benefit associated with the triplet combination of AR pathway inhibitor, ADT, and docetaxel. With Arasense, it was across the board in all risk groups. With abiraterone, it was particularly seen in our high-risk volumes, but with a clear benefit in RPFS and trend there too. So clearly, we're seeing, an evolution of the field from treating patients with ADT to combinations with AR pathway inhibitors to triplets. What about that radiation therapy? It's interesting. We wanted to bring this up because I think it's been somewhat of a misunderstood area. There was a study in Stampede that looked specifically in patients who were on ADT to receive radiation therapy to their prostate. Now, this was done at a time with just ADT, so this was not necessarily in combination with AR pathway inhibitors. And what we found was in our high volume patients on ADT alone, there was no benefit, probably because they were progressing quickly on ADT alone. But in our lower volume setting, we did see a benefit, a survival benefit in that subgroup. It's a subgroup analysis, so recognize that. And I think because of that, there's been an interest in consolidating there in the low volume patients. But in piece one, where again, we looked at patients receiving standard of care, which originally was ADT and abiraterone, and then became, ADT and docetaxel. These patients, ADT alone, and then ADT and docetaxel. The patients were randomized to abiraterone or abiraterone and RT. And in the low volume patients, there really wasn't any difference in overall survival. But what we did see was something that was really important to recognize: a decrease in the time to serious genitourinary events. What are serious genitourinary events? Well, urinary obstructions, bleeding, and pain. These are due to large volume disease in the prostate. And if you see a patient who, at their diagnosis with metastatic disease, has a high volume disease in their prostate, it's something to bear in mind. We've all had these patients that have had really serious, morbidity associated with bladder outlet obstruction, requiring, either Foley catheters, nephrostomy tubes, or suprapubic catheters. Complications, these are not perfect remedies, and other issues, really impacts on quality of life, even diverting ostomy. So this is something to recognize a risk, maybe not up front, but with disease progression in time. So it's something in these kind of patients that have, high volume localized disease on these therapies, that there may be a role for radiating while the tumor is sensitive to hormonal therapy. Now, chemotherapy, as I mentioned, has also independently shown a benefit in this patient population, sort of in parallel to our AR pathway inhibitors. And these were the studies that showed it, really predating our AR pathway inhibitors. Both Charted and Stampede showed clear survival benefits, one more than others, but nonetheless benefit associated with docetaxel chemotherapy. But it's really in the context now of this that followed our AR pathway inhibitors, and 4 studies: Titan, Arches, Latitude, really the first one, and most recently Aranote, all demonstrating benefit, certainly in the radiographic progression-free survival and overall survival for those first 3, with Aranote showing at least a trend. It's a later study. We'll have to see that data mature over time, but there's every reason to believe those results will be similar to what we see with the other AR pathway inhibitors. So I think this is an important, recognition for, in parallel to docetaxel, what was happening. And then there were 2 studies to look at the triplet combination. Piece one, which again came on when there was a standard of care of ADT, and then docetaxel became the standard of care. And in that context, we could look at that standard of care of docetaxel and ADT versus docetaxel, ADT, and abiraterone. And here you see a significant benefit associated with radiographic progression-free survival. Arasen's, looking at an overall survival endpoint, also showed a benefit. And we did see a more modest overall survival benefit with piece one. With Arasen's, we saw, if anything, a more dramatic benefit, with the curve separating early and getting wider over time, with a hazard ratio of 0.68, really demonstrating, even in the context of docetaxel, the benefit of an AR pathway inhibitor. So which patients are benefiting the most from these AR pathway inhibitors? This was at our GU ASCO meeting earlier today, and presented by Dr. Fisher, with our own Dr. Dorf here presenting the discussion, and a really interesting and important assessment of this population. And I think in many ways really validating that there's a broad benefit across this patient population, both in terms of the studies, but also I think in terms of the patient populations. And if you look here in the box, just a summary slide showing no clear difference in the effect of AR pathway inhibitors based on volume of disease, timing of the metastatic disease, de novo or metachronous, clinical stage, high volume, low volume, localized disease, Gleason score, nodal disease, sites of location, performance status, et cetera. So there's overall benefit. There was a slight difference in terms of age, but there's still a benefit. And I think we don't want to generalize too much. We still want to treat our patients regardless of age with these agents when we can. Now, on treatment, there's some interesting findings, and particularly when it comes to PSA. And PSA, as you know, is a great biomarker for androgen receptor pathway inhibition. It is essentially a reporter gene for inhibition of the AR receptor. And what we can see here is the effect when we achieve a PSA less than 0.2. Why 0.2? I don't really know. I mean, it's a little bit arbitrary. Historical assays stop there, but our current assays go down another log to 0.01. And the truth is, if we look at less than 0.01, data looks even better. So we want to drive this down as much as possible. But when we achieve that, it's tremendous benefit, both in terms of radiographic progression-free survival and overall survival. But the converse is true as well. If you have a PSA that hasn't gotten down to 0.2, regardless of where you started, this is a patient population that's at risk for disease progression. You can see there 40% of these patients progressing within 18 months. And median survival for those that didn't achieve that PSA less than 0.2 of about 3 to 4 years, the same as ADT alone. So this is something to beware, some areas where we talk about the need to intensify with additional therapies, both with chemotherapy, but maybe with precision strategies as well. And precision strategies is where this field is going. And so if we look here, we'll start at noon at the top here with loss of PTEN, PI3 kinase, AKT mutations. These are prevalent early in disease. I think Dr. Fazazi's curve said somewhere around 18%, 20%, and they go up over time. It's something selected for in the context of castration resistance. So it's a driver biology in this disease. Triple negative, if you will, for prostate cancer would be the loss of PTEN, RB loss, and P53 loss. These are patients that have particularly poor prognostic disease. They're more likely to develop neuroendocrine or small cell cancer, and these are patients we can think about using combination approaches with taxanes and platinum agents. I should mention on the top there, for our PTEN loss, PI3 kinase mutation pathway, there are drugs, there are AKT inhibitors in development today to look specifically at blocking this pathway before it becomes the driver biology, while these patients are still sensitive to AR pathway inhibition. And it's really that opportunity that we look forward to seeing in the future. So again, the triple negatives, the combinations with chemotherapies, the patients that have presence of HR mutations clearly benefit from the combination of AR pathway inhibitors and PARP inhibitors in the castrate-resistant setting. The studies going on in the hormone-sensitive setting will hopefully read out soon or are ongoing. And this is a tremendous opportunity to see if these results are even more robust in these earlier disease settings. The presence of SPOP mutations may be a marker of greater sensitivity to the AR pathway, and they may only require ADT and AR pathway inhibition, even in the context of high volume, high grade disease. So maybe an opportunity not to have to add triplet therapy. For our patients that achieve a 6-month PSA, is there an opportunity to potentially de-escalate? It's a good prognostic indication. Is this an opportunity for us to be able to say to these patients, hey, let's think about some survivorship issues and managing them? The RB intact CDK4 inhibitors for patients with MSI high or in some cases TMB high or both. These are situations we can think of PD-1 inhibition. So a lot of things. And then finally, our high SUV PSMA positive PET scan patients. There's a study that we're awaiting the results to see if using a lutetium-177 PSMA targeted therapy could add to the disease-free survival, the relapse-free survival, and potentially overall survival in that setting. There are other PSMA targeted strategies out there, antibody conjugates and other things as well. So I'm just going to end with a few slides here. One, Ironman, this is a large international registry of real-world data. Real-world data is going to be important to understand how all these clinical trials translate into the patients that you and I treat. These are most likely patients that wouldn't go on a clinical trial even if we were available for many, many reasons. And recognizing their frailty, their comorbidities, their limitations, and how these drugs are tolerated is really important. This study has collected now over 4,400 patients, and it's really given us great insights regarding what results are translating and which ones aren't, where the unmet needs are. Understanding genetics in this disease is critical, and having registries that go broadly across populations is really important. The PROMISE registry was another large effort with thousands of patients collected that I think will give us great insights into where some of these rare alterations are and what their differences are in the natural history. We need tens of thousands ultimately, but these are great efforts to really grow these.
Do you still recommend triplet therapy for any high-volume metastatic hormone-sensitive prostate cancer? Maybe Dan, Tanya?
Yeah. I'll start and we'll hear what Tanya thinks as well. So, for me, it starts with that first question, are they a chemo-fit patient? Because if they are, and this is a patient I think, has high-risk disease. I'm going to say high volume or high risk. What do I mean by high risk? The visceral disease, or patients that have 3 or more bone metastasis, and that's not a lot of bone metastasis, and high Gleason score, 8, 9, or 10. These are patients that clearly benefit from the triplet therapy. So to me, it's the vast majority of our metastatic hormone-sensitive prostate cancer patients, the de novo ones at least. So yeah, I do talk to them about chemotherapy. It's the best benefit of chemotherapy is that 6 cycles up front. We see survival benefits there much greater in both ARASENS and in PEACE-1 than what we see with our old TAX-327 studies where we get a couple of months of survival benefit on average. So to me, if they're chemo fit, if we're going to do chemotherapy, it's the best time to do it. So that's kind of how I think about this.
Tanya,
I agree, but I also am open to clinical trials in that space because as good as docetaxel is, and it has this track record, we don't actually know how much it's adding in the triplet regimen, right? The studies were done asking the question of on top of docetaxel using the AR pathway inhibitor rather than the other way around. So I definitely speak to patients about it, but if I have a triplet trial with something novel, whether it's a PSMA radioligand or a PARP inhibitor, or the CDK4/6 inhibitor before the trial reported out negative, I still think it's perfectly valid because we need additional treatment options, and some chemotherapy candidates don't want to do chemo for one reason or another. But I definitely think it needs to be offered and discussed if we're going to look at other strategies as well.
It's because all the things you name are precision medicine. And ultimately, that's what we know is working in this, not just prostate cancer, in a lot of fields. And particularly in combinations, precision medicines, they work okay as a single agent, they work even better when we do them in combination. So I love that comment because I think it's so important to recognize chemo is not a precision medicine.
Excellent, thank you for that. Maybe a more specific question about those intensifications. This is first, congrats you for the presentation. So this is a gentleman with MCSPC with de novo pulmonary metastasis. Rare situations, but of course we serve them only. No bone mets, no lymph node. I don't know whether this was biopsies or anything, but let's assume that indeed we're sure that it's a true metastasis, because sometimes you don't really know what's in the nodules. Gleason 7, PSA doubling time 10 months. Would you go for doublet or triplet, local therapies against those pulmonary metastases? Hard to answer, but what would you do?
So pulmonary metastases count as visceral, making this patient, at greater risk for early treatment failure. If it's a solitary lung metastasis that's biopsy proven, the data we saw today about using SBRT to oligometastatic is very interesting, but I'm not sure how many of those patients were lung, right? I think it was overwhelmingly bone or lymph node. So I've had a few of these patients in my clinic. I feel like chemotherapy is a right choice, so I would definitely be talking about triplet to this patient.
Yeah, and I agree. I think these are, it's hard to generalize on these, but I do like the idea of giving patients one chance at a kind of a focal, metastasis-directed approach in this, and you're going to know pretty quickly. Especially if it's PSA producing, you're going to know pretty quickly if you've made progress there. So doing that, if they're asymptomatic, holding on to hormonal therapy a little bit just to see what that response is, and then being able to know, okay, yeah, we didn't get a PSA response, we really need to be treating them as a systemic metastatic patient or not. So yeah, I think it's open to debate. I don't know if there's a right or wrong answer here, but I tend to, if the patients are low volume and asymptomatic, give them a chance at metastasis directed.
Thank you. And just for the audience, I just want to remind you that there are now clear data regarding visceral metastasis indicating that we should separate liver and lung metastasis, where they don't behave the same. Obviously, liver metastases are much more aggressive and much less sensitive to many of our treatments, unfortunately. Pulmonary metastases in general are quite hormone sensitive, with probably more SPOP mutations in this population of patients. So again, if you're facing a gentleman with pulmonary metastasis, you can tell him, that it's not necessarily a catastrophe. I would love to say the same thing for liver metastasis, because usually it's not good. The other way around now. We've been speaking about intensification, but this colleague is telling us that now that we have some patients can benefit from de-intensification, so what tools can help for treatment selection, for de-escalation of treatment? If ever you're going for de-escalation, if some of your patients, how do you make your decision?
Yeah, I think that, there's a few things we can use. As I mentioned earlier, that PSA response is really helpful, particularly as patients that get to an undetectable PSA, and not just less than 0.2, but all the way down. I think secondly, what was that original genetic profile? Remember, we talked about, being able to know if these patients harbor some other genetic alterations, because if they do, I get a little bit more uncomfortable stopping therapy in somebody that has a P53 or a loss of P10 or RB or other features associated with it. Conversely, if they've got an SPOP, as you mentioned, these are patients I feel quite good about their undetectable PSA as being really an AR-driven tumor in stopping therapy in those patients. I do think, there's real value in being able to allow patients to recover. Survivorship is a major issue, and our chronic hormonal therapies in these patients can, really limit their long-term survival, particularly in some of our older patients. So it is an important factor to consider, but just recognize that it also requires really good follow-up. I've had more than one patient lost to follow-up, come back with high-volume disease. And it's heartbreaking to see that, see a patient who was under control come back with a disease that's not. So it's really important messaging out there.
Agree. Dan, let me ask you one question. Maybe I will ask Tanya the exact same question. Let's say it's a scenario of a man who had whatever 4 bone metastases or whatever we like, and after 6 months of treatment, PSA is down to 0. Treatment is still tolerable with the current, the normal side effect you would expect, but nothing terrible, no, cardiovascular issues, etc. Just, classical tolerance to treatment. How long do you typically treat this gentleman? Do you stop? Do you keep on going for a couple of years? Do you treat forever? Your typical current recommendation or discussion with the patient, what would you say? Well, Tanya first, maybe.
I like 2 years. I mean, it's pulled out of sort of a hat, sort of stampede, but I think patients with metastatic prostate cancer need a certain amount of treatment before I'm ready to give them a treatment holiday. I will say even with that, it's only patients who are struggling with side effects, patients who have a good quality of life and don't have excessive weight gain or other things that make me worry about their overall long-term health, I think should stay on treatment, because universally my patients who do get holidays, the cancer comes back, and that's okay. You just have to prepare them. PSA will rise, you'll be back on treatment, but maybe you'll have some time with testosterone recovery.
Yeah, I agree. I like some time too. I mean, at least a year, probably it's usually between 1 and 2 years, somewhere in that time frame. Once you go beyond 2 years, it's hard to recover testosterone. So I worry a little bit like it's a hollow victory to stop. So it's usually somewhere in that window. I do like for these oligo patients to radiate those bone mets. I mean, I will say that, and maybe I'm like extrapolating too far, but like this Piece 3 data where we used radium, and it was castrate-resistant disease, but nonetheless they were hormone responsive, and to enzalutamide and added radium, and there was a huge survival benefit associated with that, a real prolongation. So to me, in the hormone-sensitive setting, if we can kind of mimic it with our little, SBRTs to a few spots, I like to do that. A little more kind of not so sure about the primary. It depends if it's big and it's already a little symptomatic and things. But the bottom line is that just try to give us the best chance of getting a treatment-free interval with some testosterone recovery.
Maybe one comment regarding the irradiation of the primary. We were happy to see in Piece 1 that indeed, if you're irradiating the primary in patients with metastatic disease, regardless of the number of metastases, you're significantly preventing the onset of local progressions. But one surprise to me was to see that when you look at T3, T4, as you just said, big local cancers, you do see a benefit. And if you're also looking at T1, T2, smaller tumors, you still see almost the same benefit.
That's right.
So that made me change the way we are recommending now radiation therapy. And I actually now recommend upfront radiation to all my patients with de novo metastatic disease. Regardless of how big is their primary cancer and regardless of how many metastases they have.
When you say upfront, so like after just a couple of months, or do you wait to see they get to the undetectable PSA?
Well, what we had in the CRF was baseline. So that was before treatment, before systemic treatment.
Oh, really?
Yeah.
Yeah.
So, and it doesn't make a big difference in terms of the preventive effect of radiation. Of course, it makes a difference in terms of incidence. Bigger tumors are more likely to remain big. But in terms of the preventive effect of radiation, it works. Let's speak about, because Dan very nicely set the scene, I guess, with what we know. We showed you the evidence when we spoke about maybe non-evidence and what we do in our practice based sometimes on feelings. But let me show you where we are now and maybe how the biology may help us, and Dr. Dorf will complement what I will say. So maybe some recommendations, and of course you can take it the way you like, based on evidence here. Let's separate different scenarios. First, de novo patients. And Dan already alluded to that. These patients typically don't do well, as opposed to patients with recurrent metastatic disease who actually do quite well, approximately 8 years of survival for those men with recurrent metastatic disease after the diagnosis of a first metastasis. So, nothing terrible in the short term. But for patients with de novo disease, again, worse prognosis. For low volume disease, you may argue that we should go for doublet when it comes to systemic treatment, but actually triplet also works in terms of rPFS, and the magnitude of the benefit we're seeing with triplet therapy is actually pretty much the same for low volume and high volume disease. It's just that when we analyzed PIS1 and Erasence, most of these patients were still alive, so overall survival was really not mature. We hope to reanalyze PIS1 with a much longer follow-up this year to see what is the actual benefit, if any, in overall survival with the triplet. So stay tuned, hopefully we'll have data this year or soon. Prostate radiation therapy, at the very least, prevents GU symptoms, as we just showed. There is no clear overall survival benefit, and we may debate why STAMPEDE showed, or should I say, suggest an overall survival benefit for patients with low volume disease. Actually, it might come to difference in the imaging techniques that were used in STAMPEDE versus other trials, including HORAD and PIS1. And indeed, in STAMPEDE in the UK at this time, they were using planar bone scintigraphy without correlation to CT. And actually, there might well be some false positive metastatic patients included, and those the overall survival benefit related to radiation in this scenario. Of course, I don't know. So, prostate radiation, at least you will prevent the event of GU symptoms, and actually quite dramatically. So it's quite cheap, at least in my country. It's quite well tolerated as well. So I feel very comfortable recommending that to my patients. For high volume de novo, it's pretty much the same discussion, actually. Yes, it's a little worse in terms of outcomes as compared to low volume de novo, but actually you may debate triplet systemic therapy, and we just spoke about the preventive role of upfront radiation even in these patients. Now, having said that, a totally different scenario is that of low volume and relapse. These patients per se have really good outcomes, even with ADT alone. RP should probably be added on top of ADT, and I'm saying probably because that comes from subgroup analysis, and actually quite small subgroups from many of these randomized trials. They're mostly accrued patients with de novo disease, but the data point towards that direction, a benefit of doublet. So I think this is a reasonable recommendation to make. Regarding SBRT, you saw the data today, more and more data supporting SBRT, but we still don't have level 1 evidence, no phase 3 trials available. We just completed like a week or two ago the accrual in our European P6 oligo trial looking at SBRT with more than 500 men randomized, and now know that some other trials are ongoing in Canada, here in the US, STAMPEDE is starting, etc., etc. So eventually we will know whether SBRT is really needed, but we need to be patient. These phase 3 trials will need some time to read out. And hopefully all what I just said on this slide will be completely obsolete in a couple of months, thanks to biomarkers, and I really hope this will come soon. So let's speak about biomarkers. PTEN, for example, is very clearly shown to be associated with poor outcomes. And actually, if you're looking at PTEN deficiency incidence in patients with localized disease, you will see that approximately 12 patients have that. Now, when it comes to metastatic castration-sensitive disease, we probably don't have robust public data as I'm speaking, but let's say it's around 20% or so. And for mCRPC, it's even more than that, approximately 30%. And across all these fields, it's clearly associated with poorer outcomes. This is one example, a study showing that. You can see a clear hazard ratio for poorer outcomes, and this is overall survival, by the way, in patients with PTEN deficiency in prostate cancer mostly, because there might be some other means at targeting or silencing PTEN in other diseases. Why is that potentially important clinically, besides the prognosis? Well, in patients with PTEN deficiency, the AKT PI3 kinase pathway is activated constitutively, and this occurs in parallel to the androgen receptor pathway. And actually, every time you will target, for example, the AR pathway, you will stimulate the other pathway, and vice versa. If you're targeting the PI3 kinase AKT pathway, the AR pathway will be on. So if what I'm showing here on the screen is true, and those are data coming from the lab, you should actually target both pathways at the same time if you want to get the efficacy. This was actually done, I think, very elegantly in a randomized phase 2 trial testing abiraterone alone or in combination with ipatasertib, which is an AKT inhibitor. And this randomized phase 2 trial supported efficacy from this doublet in patients with PTEN loss, to the left-hand side on this slide, while for patients without PTEN loss, well, abiraterone was doing the job with no additional efficacy related to the combination treatment. And what I'm showing here with 400 milligram dosing was also reported with 200 milligram dosing of ipatasertib. So it's a confirmation if you want. So that led to a rationale for conducting a randomized phase 3 trial, which you can now see on the screen. You can see the design. These patients had metastatic castration-resistant disease, big trial, more than 1,000 men were randomized. Tumor PTEN loss was assessed by immunohistochemistry, and I'll come back to that in a second. And these patients were randomized again to receive abiraterone alone or combined with ipatasertib, and they were randomized on a 1-to-1 fashion. And you can now see to the below part of the slide that it's a positive-negative trial, if you will. It's a positive trial because the p-value is significant, 0.03. And indeed, the combination did a better job at preventing radiographic progression or death as compared to abiraterone alone. But it's negative because the magnitude of the benefit is not exactly what would you like to see to support using this in your practice, or at least this is what the regulators decided doing, and it makes sense. There was no overall survival benefit supporting this modest PFS benefit. So why is that? One first explanation is about how you look at the biomarker. As I told you, in this trial, immunohistochemistry was used, and immunohistochemistry isn't perfect. Now, if you're looking at NGS assessment for PTEN deficiency, and this was done in parallel, but not used for decision-making for randomization, you will see that the benefit is actually greater, supporting better efficacy for the combination in patients with truly PTEN deficiency by NGS. The hazard ratio is now 0.65 instead of 0.77 in favor again of the combo. So the biomarker makes a difference. Now, something else. when you're moving from phase 1/2 to phase 3, I think you really need to make sure you have the optimal regimen safety-wise. And indeed, if you're looking at grade 3 and 4 toxicities in these trials, you will see that there were many more events in the combination arm to the right-hand side, here in blue, as compared to abiraterone alone. And indeed, many of these patients had to either discontinue or have dose interruptions or dose reduction. Now, there are other options for AKT inhibition, and for example, capivasertib is being developed, both for prostate cancer and for breast cancer. In breast cancer, indeed, we saw great news from a randomized phase 3 trial. The combination is better than single agent, and hopefully more women will be able to benefit from this combination. Now, for prostate cancer, we saw a phase 1/2 trial of capivasertib combined with abiraterone. And as you can see, the degree of toxicity, and of course with all caveats regarding comparison of trial versus trial, it appears that the safety is perhaps better than what I just showed you with the other AKT inhibitor. You can see here the grade 3, for example, in dark. This is really a minority. Again, with all caveats for those comparisons. We're just waiting for public data regarding a phase 3 trial called Capitello 281 in patients with de novo metastatic castration-sensitive disease and PTEN deficiency, again determined by immunohistochemistry with central testing. And in this trial, patients were randomized to receive abiraterone alone or combined with capivasertib. We just saw a press release out just before Christmas, so kind of Christmas gift, showing that the trial is positive by its primary endpoint of radiographic progression-free survival as compared to ADT and abiraterone, so good news. The overall survival data were immature at the time of this analysis, so probably we will need a longer follow-up to see the data and mostly to see overall survival data. The good news is that these patients now do much better than they used to do in the past. And again, this is simply great news. It makes things more complicated when it comes to clinical research, but at the end of the day, it's great news for patients. What else do we have? This is, for example, the P6 platform that we have in Europe. So this is all academic phase 3 trials, and we are asking different questions in different populations of men. First randomized trial is for patients with oligo disease. And as I just said, we just completed the accrual of a trial randomizing standard of care, the one investigator wanted to use, versus the same, plus stereotactic radiation therapy directed to the detectable metastasis. And by the way, PSMA PET or choline PET was used to detect oligometastatic disease, not conventional imaging or old-fashioned imaging, should I say. Second trial, we are also trying to focus on patients with vulnerability, patients you never see in trials. So this is a quite small window of a patient that you don't feel comfortable treating him with, say, abiraterone or enzalutamide or apalutamide, drugs that are already on the market, but not, too frail to still be able to tolerate something. So we were wondering whether we could do such a trial, and actually it works. We have now more than 100 men already randomized, and the actual curve is almost exactly parallel to or similar to the theoretic curve for accrual. So that's great. And we're randomizing the role of darolutamide, which is usually very well tolerated. Now, as Dr. George said, we have a very simple tool and good biomarker, and cheap, by the way, which is called PSA. If you're measuring PSA at 6 to 8 months after the onset of systemic treatment, you know much of what's going to happen to your patient. Patients with a PSA down to 0 do mostly well. And for this patient, our plan is to go for de-escalation, as we just discussed it informally. While for patients who are poor responders, those with detectable PSA at this time, we have just started last summer a randomized trial testing addition of lutetium PSMA on top of ongoing systemic treatment, with the hope that this early intervention will prevent or delay progression and hopefully death. And patients have been already randomized. So let's discuss a bit and let's see if we have more questions. PTEN loss by immunohistochemistry is enough for molecular risk stratification and therapeutic decision, or is it necessary to use an NGS?
Well, I think if the study's being done with IHC, then we're most likely going to need to use IHC. I mean, the regulators will decide what the criterion will be, but certainly if we see a P10 alteration on NGS, that would be a patient we would think about using the approach, even if we have to confirm it with IHC.
And the truth is there's probably other ways that P10 can be knocked out besides at the genetic level. So to me, IHC is sort of probably our gold standard. And my hope would be that this would be kind of a reflex test with our pathologists, and that's what we're talking about at Duke, certainly in breast cancer, and then in maybe in prostate cancer, be able to have that for patients that, have these high risk, metastatic disease tumors, to be able to kind of reflex and have that tested, so you don't have to separately order it. And I think it's something you can talk about. These are available. This is something that pathology can build into the algorithm, and that would be my hope if this is becoming a new future standard of care.
Do you know in Capitello 281, were they staining mostly prostate primary tissue, or were they requiring biopsies of metastatic sites?
I think it was mostly, the data are not out, so I'm not going to comment too much, but I think it was mostly prostate biopsies. And just to complement, there might be, besides immunohistochemistry, NGS, there might be also signature, looking at, what PTEN loss has as in terms of consequences. And that might be actually another opportunity to better understand the biology of the disease and maybe to better identify those patients in whom this pathway is actually on. But let's look about it. And with that, let me ask Dr. Dorf to give a talk about prostate cancer precision care targeting key signaling pathways. Tanya, please.
Thank you. So I'll be addressing primarily castration-resistant prostate cancer, and I'll start with a patient of mine who noticed a neck lump and unexpectedly was diagnosed with prostate cancer that way with a very high PSA. He had bone mets, elevated alk phos, clearly an aggressive presentation. He was started on doublet therapy, achieved an inadequate PSA nadir, so we knew he wasn't going to have as long a remission, and then rising PSA around 2 months. Bone scan shows faint uptake in a right eighth rib with sclerotic change on CT, but otherwise nothing new. And in his remission, we had imaged him and the lymph nodes had gotten a lot better. So this is sort of an early, slow progression, and this is a very common scenario that I see in my practice. And we have a lot of options. So with prior intensification, such as this patient, right now the default is sort of chemotherapy unless the lutetium PSMA 617 moves to before chemotherapy. We can use radium. The ACCME trial used both pre or post docetaxel. There is still a role for sipuleucel-t in someone who's asymptomatic or minimally symptomatic. There's an option of bipolar androgen therapy. And of course, there could be PARP inhibitor options, monotherapy, if there is an HRR alteration. So a lot of choices. If this patient had not been on a doublet, we would now have these new ARPI PARP inhibitor doublets as options, or the PEACE-3 regimen of enzalutamide with radium-223, assuming we get regulatory approval for that. And then some of the other same options. So this is a mess. So what is the approach? How do we simplify this? Number one, we do our germline and somatic DNA testing. Number two, so while we're sending that off, we're ordering the imaging so that we can get a sense of the radiographic pace of progression. And then, of course, we look at the patient in front of us. Are they having more pain? Are they being less active? Is their alkaline phosphatase getting elevated? Are they becoming cytopenic? Those are all things that factor into whether we're going to pick a more aggressive treatment option or something a little bit lighter, so to speak. So germline and somatic DNA testing are both very important in prostate cancer. Either one can qualify a patient to receive a PARP inhibitor. And if we just do somatic testing, then the patient misses the opportunity to inform family members of a potential risk gene that could impact their cancer screening. So cascade testing is really important, and that's why we don't just do somatic testing. We want to do germline as well. So there's a debate about whether you need to do both right up front, since the approvals right now that are based on NGS findings are really in CRPC. If you do your testing all up front, you have to remember that somatic alterations can occur as a patient's being treated. Dr. Fizazi alluded to AR mutations, which really only are seen in CRPC and usually post-AR pathway inhibitor. You can develop an HRR alteration that was not present initially during exposure to treatment. So there are pros and cons to when you do that somatic testing, but serial testing is reasonable. And yet real-world data tell us that unfortunately not all prostate cancer patients are being offered DNA sequencing. So we can see that about 20% of patients in this example of a real-world data set had germline only. At least they got something, right? Another 60% got somatic only, and a really small percentage got both. So there's room for us as a community to do better. I'm not 100%. I offer germline testing. Some patients are not interested, even if their wife is really pushing them. So it's not always on us. It's, obviously there's two sides of the story, but we certainly should be thinking about it, offering it, and there are ways to access it even if you're not at an academic center that has genetic counseling, things like the PROMISE registry that was mentioned earlier. Even more surprisingly, some patients who have DNA sequencing and have an HRR alteration are not offered a PARP inhibitor. It's hard to know. We're not in that clinic room. We don't know all the particulars about the patients. But I think we've seen over and over again the story that if you have an HRR alteration, and particularly BRCA, you can tremendously benefit from PARP inhibitors. So Triton-3 was a very impactful study from that perspective. So that was rucaparib versus physician choice. And physician choice could either be chemotherapy or AR pathway inhibitor switch. And in the patients with BRCA alteration, you can see that compared to control, rucaparib was much more effective. And that was true whether it was docetaxel or an AR pathway inhibitor switch. So this was sort of the first study that showed us that head-to-head against chemo, when you have a BRCA alteration, the PARP inhibitors are just so effective, and we want to use them sooner rather than later. It's been challenging with some of the smaller, the less frequent genomic alterations to understand whether those patients can benefit from PARP inhibitors. This FDA pooled analysis that was published in JCO last year is a very, very helpful reference. Overwhelmingly, the data seem to point to the fact that patients with ATM alterations don't seem to have a particular sensitivity to PARP inhibition, but other alterations like CDK12 and PALB2 do seem to be sensitizing, although not to the same extent as BRCA2. So I think we're learning more and more. A couple years ago, we didn't really have enough data to talk about these subsets in a meaningful way. So this is a summary of PARP inhibitor approvals. So in monotherapy, we have olaparib based on PROfound, which had a set of genes that qualified, and it could be either on tissue testing or on blood testing, liquid, ctDNA. Rucaparib, based on Triton-2, is FDA approved for patients with a BRCA alteration as monotherapy. The PARP inhibitor combinations include olaparib and abiraterone based on PROPEL, which received FDA approval for patients with a BRCA alteration. Niraparib and abiraterone based on Magnitude, which again, for BRCA alteration. And then what you saw today, talipro-2, talazoparib, and enzalutamide, which is approved for a broader indication of HRR altered. So all of these were done in first-line mCRPC, right? So patients who had not progressed on an AR pathway inhibitor. But for a patient who is developing CRPC just on castration, these are good options, and this is a compelling reason for us to remember to do our germline and somatic testing. So we've done our DNA sequencing. Now let's turn to the imaging. So Cougar 301 and 2, which were the trials pre and post docetaxel that got abiraterone approved, and Affirm and Prevail, which got enzalutamide approved, did not stop treatment and switch on the basis of PSA rise only. And Howard Scher published this very helpful case example many years ago of a patient with enzalutamide in CRPC, drops the PSA, and then it's slowly rising, slowly for years, because they're imaging every 12 weeks. And only at this time point is there radiographic progression. So if you pull the patient off the drug, they're actually doing fine. They feel fine, their scans look fine. And this is how we understood part of the benefit of these medications, is that they drop, they debulk, and then slowly resistance emerges, but all is not lost and we don't need to abandon the treatment. And then he showed this palliative radiation, which is what we're talking about more today as SBRT to oligoprogression. Our terminology has sort of changed, and the PSA drops and you can continue the patient on the same treatment. So I think it's just important to remember that it's not a race to get through all our lines of treatment. We want to get the most out of each line of treatment that the patient is on. Sipuleucel-t is another option for someone who's slowly progressing, asymptomatic or minimally symptomatic. We know it's not going to create this kind of a nice drop in PSA, but it is associated with prolongation of overall survival. Now, if someone's PSA is rapidly rising, or if they're symptomatic, their alk-phos is elevated, radium-223 becomes a very nice option. And of course, we can do a PSMA PET scan. We're not using them routinely in CRPC to gauge response and progression, but when we're starting to think about applying radioligand therapy, then we need that PSMA PET to help us identify whether this patient can benefit from application of radioligand therapy. And then, of course, if your imaging ends up showing, instead of just this one little rib met, as in the case scenario, if it shows liver metastases, those are a different kind of prostate cancer progression. We want to biopsy that. We want to look for neuroendocrine differentiation. We want to maybe send off some DNA sequencing from what is happening now, because this cancer has de-differentiated. So PSMA has become a validated target. We know it's an extracellular binding domain, so we can approach it with an antibody or a small molecule. And then if we link that to a radioactive particle, then we can deliver the radioactivity through the bloodstream to cancer cells that express this target. And the VISION trial involved lutetium-177 PSMA-617 in patients with metastatic castrate-resistant prostate cancer who had received docetaxel. It was really compared to standard of care, which was only allowed to be an AR pathway inhibitor, so not compared head-to-head against something like cabazitaxel, although we have the therapy trial that fills in that gap. But the VISION trial led to FDA approval of PSMA radioligand therapy. The criteria for enrollment on the PSMA PET was simply to have at least one metastasis that had more uptake than background, which is defined as the liver uptake, and no soft tissue metastases that were quiet. You can have quiet bone mets on your PSMA PET, but you can't have quiet soft tissue mets. So there's a summary of the VISION criteria. The therapy trial compared lutetium PSMA-617 directly against cabazitaxel, and they had a more stringent PSMA PET criteria for entry. They required an SUV max greater than 20 for at least one of the metastasis and at least 10 at all the measurable metastatic sites, and they did FDG PETs to look for discordance. So most of us are not doing this in our practice. We really rely on the VISION criteria, but they did have a very high response rate, and perhaps it's because they selected patients who could receive more activity in their treatment with radioligand. And the quartile data shown over here shows that the more uptake, the longer your progression-free survival, because we're just delivering more of the treatment to the cancer. But there are other ways to target PSMA. We can deliver something else besides a radioactive payload. There are bispecific T-cell engagers that look for CD3 and then for PSMA to try to bring T-cells into the tumor microenvironment. One study, AMG 160, I was part of, had really high response rates. Like clearly the immune system was engaging, as you can see in this waterfall plot. But the rates of CRS were very high. There was some CNS toxicity, and unfortunately, it was not felt to be manageable for the broader oncology population, although there are some other bispecifics that may be more applicable and are moving into phase 3. The PSMA ADC, so you can deliver a chemotherapy payload targeting PSMA. And so there are some experiences already showing some responses. The chemo payload often is a microtubule, so we do still run into neuropathy. But this is, and now that it's been proven that we can target PSMA and achieve responses, there are different ways we can target that. And there are other targets as well. So STEAP1 is highly expressed, and the AMG 509, which is now known as xaluritamig, has a 2-to-1 ratio of targeting STEAP1 and CD3. So this was from our phase 1 experience. You can see really, really strong response rate. The rate of CRS was much less, and the toxicity is much more tolerable. So the phase 3 open, we put the first couple of patients on at City of Hope, and we're really excited. They are randomizing 2-to-1 against xaluritamig versus physician choice, and they are allowing chemotherapy, which is cabazitaxel, in the physician's choice arm, or AR pathway inhibitor switch. So I think it's a really good trial, and I think I've seen a lot of patients benefit from this treatment. I'm hopeful that this might end up being a new option. Some other good targets, HK2 is widely expressed, and this is being targeted with an actinium-225 radioligand. Michael Morris presented data at ASCO last year showing very nice responses. There are some toxicity concerns, and we have a bit to learn still maybe about alpha particle therapy compared to the beta particle lutetium-177. And then once a prostate cancer becomes dedifferentiated, it doesn't express PSMA or some of the other targets, and we're looking at new targets to try to approach this population. Rahul Agrawal presented these data at ASCO last year using a DLL3 targeted bispecific. And as we learned about with the PI3 kinase AKT inhibitor, you need to define your population, the PTEN loss. Here, you really needed to have DLL3 expression, and that was not uniform, which is why I think the response rates look relatively low. So we talked about repeat NGS. So when we look back at our patient case, you can see there are lots of different options. It's complex, and it requires a balance of the patient's goals, how much they're willing to invest in their treatment, how many side effects they're willing to tolerate, how many clinic visits. So it's a robust discussion for shared informed decision-making, but at least we have a lot of options. That's a better place to be.
I think this is also interesting biology. We know that for 20 years, basically, but we didn't do much about that. Actually, when you look at it, to the left-hand side, you will see wild-type AR and androgen, of course, binding to the C-term part of the AR. But in most mutations, the androgens no longer bind to the AR, but those are other hormones, including, for example, corticosteroids, progesterone, estrogens. So in other words, in these patients, if you're using whatever abiraterone you like, whatever enzalutamide you like, it's not going to work anymore. You need either to invent new compounds targeting the mutated C-term part, which is, or PROTAC AR, for example, to just destroy this mutated form of the androgen receptor, or try to remove those alternated hormones, such as corticosteroids and progesterone. This is actually something we've tried to do, targeting CYP11, not CYP17 that you probably know thanks to abiraterone, but CYP11 is actually the very first enzyme downstream the cholesterol that allows the making of all steroid hormones. So you're completely blocking the making of mineralosteroids, glucocorticoids, and also sex hormones, including both estrogen and androgens. And it actually works. And the good news is that not only it works in patients with advanced disease, but again, this is precision medicine because we saw a much higher efficacy degree in these patients with detectable mutations, meaning that if this is confirmed in phase 3 trials, and actually phase 3 trials are ongoing, we will be able to identify first who are these men and decide to treat them with this agent or some others. So yes, this is another example of capivasertib in phase 3 trial, this time in combination with docetaxel, not with abiraterone, and this time in castration-resistant disease, not in castration-sensitive disease. So stay tuned. We don't have the data about this one, but the accrual is coming fast, so we should have those. Radioligand disease are being moved earlier in the course of the disease. Dr. Dorf already explained what we know about lutetium PSMA. PSMA addition, for example, hopefully will soon read out. And this is a phase 3 trial looking at lutetium PSMA, again in castration-sensitive disease, not any longer resistant disease. We also waiting probably this year for the readout of phase 3 trial looking at PARP inhibitors in castration-sensitive disease. TALAPRO-3 and Amplitude are rapidly maturing, so we should see the data anytime soon. And of course, there are other trials looking at PARP inhibitors even earlier in the course of a disease. This is, for example, the EVO-PAR PR01 phase 3 trial looking at saruparib, which is a next-generation PARP inhibitor. And there are several trials testing these agents in several situations of the disease. Any thoughts on CAR-T therapy for prostate cancer?
So yes, thank you for that question. I really believe that CAR-T therapy will become a tool. I don't think it will ever be broadly used. I think it will be for select patients, but we've seen across all the CAR-T therapy trials, some patients can have really deep and somewhat durable responses, and we're working out how to dose these, what adjuncts are needed to get it to work even better. So yeah, it's a work in progress.
All right. Okay. There are a lot of PARP inhibitors already approved for mCRPC. What do you think that additional PARP inhibitors can offer?
Well, I mean, I think one of the big questions is in these newer generation PARP inhibitors, can they be more selective? So is there a way to inhibit this DNA repair in a way that doesn't necessarily cause as much, say, hematologic toxicities? And there's really two hematologic, concerns we have. One is a common one, which is anemia, and to some extent, neutropenia. And then another longer-term issue is the development of, secondary MDS or leukemia. So having more selective agents would allow us to potentially treat patients to minimize some of the common toxicities and hopefully really lower the risk of the long-term toxicities to allow for more chronic therapy. So that to me is really the goal in this. I mean, it's not necessarily to develop more potent PARP inhibitors, but more selective PARP inhibitors.
So maybe let's take the first question that we see on the screen. What are the challenges you're facing sometimes in practice with established radioligands, so lutetium PSMA? Tanya, any comment on that?
There's a little bit of a challenge working with a multidisciplinary approach, interfacing with our nuclear medicine physicians. So we've established kind of a tumor board where the PET scan is looked at, to some extent the SPECT after dosing for like a dosimetry. There are some patients who get a lot of nausea and vomiting, so that was a little bit of a surprise to me as we started treating with the radioligand. So now I do prescribe some antiemetic. And the dry mouth, most of the time it's not so bad, it's reversible, but there are patients who really are impacted in terms of their eating. So those are some of the challenges.
Dan, any additional comment regarding challenges with lutetium?
Yeah, I think one of the other challenges with it sometimes is, whether, how to modify this. So if we have, for instance, a patient that gets a really fantastic response, PSA drops 90% with the first couple of doses, the question is where are we going with this, right? We have only 6 doses. We don't get to treat and retreat in most cases. So is there a role for re-imaging with PET and maybe stopping and doing a little intermittent dosing, over time? And then I think the other end of the spectrum is when you have a patient that isn't necessarily getting a PSA response. What do we do with that patient? Is that somebody we stop after 2 doses, or is there a role again for imaging here, maybe more conventional imaging to say, yeah, this is disease that's not responding, we need to move on. So I think some of the on-treatment decisions I think are, in practice, things to work out, because our clinical trials are sort of set what we do. They're kind of a set pattern, and they don't necessarily guide us in that kind of personalized management.
And just to support what you just said, your first comment, these extreme responders, you may become really toxic continuing while on treatment. Actually, the Australian group, what Louise reported today, decided to stop after 2 injections in these patients really responding well to treatment to avoid toxicity. Because again, if you don't see any more lesions on the PSMA PET and you inject lutetium PSMA, actually the lutetium PSMA is not going to go to the cancer cells. They're going to go to the normal cells, so you might be toxic. So that is something we should think about. Maybe a last comment about a challenge. If you're waiting too long before treating with lutetium PSMA and your patient has enormous burden in the bone marrow and in the bone, you will do a whole bone marrow irradiation, and that can be toxic. And in that scenario, you need to be prepared to transfuse your patient sometimes until the end. So be careful with those things. All right, with this, I'd like to thank you all, and a big thank you to Tanya and Dad for that fantastic event. Thank you very much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from AstraZeneca. To access all materials for this activity, visit peerview.com/ZXT860.